Hello, and welcome to the Innovation Institute of Online Education and Training. I am Dr. Tara Thompson, a pharmacist and Vice President of Clinical Services at Innovation Compounding, and I am your presenter for this webinar today. Together, we'll review the benefits of compounded medications and the many formulations available for patients with urologic conditions. This training will cover everything from the practice of pharmacy compounding to selecting a pharmacy, to diagnosis and evidence-based treatment protocols and formulations. Please remain with me after the lecture to learn how you can prescribe with confidence and broaden the scope of your practice with compounded medications. Thank you so much, and we hope you enjoy the webinar today. I am a compounding pharmacist. I'm out of Georgia, and what we typically do, especially in a urology standpoint, is build different drug combinations for urologists and advanced practice providers who are needing these particular medications for their patients. I do not intend to promote any specific company or product, but just am here to provide educational material for you and drug information and pharmacology education so that you're more familiar with the options that are available out there. The drug therapies in this presentation are not FDA approved. I will try to go remind you throughout that they are not FDA approved medications. They are compounded medications. They are available through FDA compounding facilities and FDA registered manufacturers who provide bulk ingredients to compounding pharmacies. So they are still legally prescriptions and drug options that you can choose for your patients, but they have not been through the FDA approval process as a drug. So I love to put this slide in all of my presentations just because I think it is so interesting how far we have come in medicine and then how it all kind of circles back on itself. So just for your smiles this morning, I want to start with this one. So in medicine, we all know that it began so long ago. Medicine men, shamans, magicians, exorcists, healers, apothecaries were some of the earlier terms used. And in the beginning, they would say, here, eat this root. So you would have your people mixing up roots and herbs. And actually, herbs is a big part of Ayurvedic medicine, which would be, they were actually taking the roots and herbs and form a large part of that particular area of medicine from India. So interesting. As time went on, people said, no, that root is heathen, say this prayer. So you're looking into more your magicians and your healers. 1850, we're looking at that prayer is superstition, drink this potion. So your witchcraft and your medicine men and your exorcists. Even further on, that potion is snake oil, take this pill. Oh, look, we're getting into more modern medicine, Hippocrates, and the Age of Enlightenment, where physicians were, coming into play, providers were looking at self-trained, the germ theory, all those things starting to come into play. However, as time went on, not too long ago, that pill is artificial, take this antibiotic, looking at the rise of learning more about infectious disease, viruses, bacteria. And then here we are again, 2000, that antibiotic is ineffective. Here, eat this root. So isn't that funny? We've come back to where it all started. I know that's not the case in all of your practices, but I just thought it's funny because I also work with a lot of holistic and integrative medicine docs. So it's interesting to see them wanting to go back to some of the herbal and natural ways of doing medicine. So just very interesting where we've come. And I'm sure 2020, knowing what we know today, it will have another line here at the bottom that has some sort of, funny, thing that relates to 2020. So anyways, moving on, but just something for you to think about today. I do want to go over some objectives. We hope to accomplish these things today by the time you walk out of here, obviously, knowing more about compounding in general, the purpose of compounding pharmacy, and some of the benefits and drawbacks of compounded formulations. If you already know or you already work with a compounding pharmacist or compounding pharmacy, you can
tune out if you want for the next 5 minutes, but I did want to kind of bring that to note, as there's a couple pretty interesting things that may not be known about compounding pharmacies, and also the options that it can bring your patients in your particular practices, specifically in terms of disease states that are tailored precisely to the patients that you guys are seeing in your urology, urogyn groups. So those two, starting off just a little bit about compounding pharmacy and formulations. And then the last two, we're going to dive more into prescription options for urologic conditions, which is going to be probably the most interesting and enlightening part of today, and the most takeaway messages for you as a provider, to have enlightenment on some of those options that are out there that you may not have known before. And as a pharmacist, I love to go over pharmacology, drug mechanism. Sometimes knowing how the drug is working in the body really allows us to use it in different places, in different dosage forms, and I hope to pass that along to you too. The last one is just to determine appropriate formulations. So we're going to look at dosing, strength, frequencies, different dosage forms that may be more appropriate than others, depending on the patient. So we will get into all that. The next slide is just a little bit about compounding. So if you don't know, compounding pharmacists work with providers all over the nation. We work with all different types of providers. We work with prescribers, clinicians, even therapists and counselors, to come up with customized medication solutions for patients whose needs cannot be met by a commercially available or a manufactured medication. So we'll go over in a little bit some of the candidates for compounded medication, and who those patients may be that walk into your office or your practice or your exam room and say, I've tried this and this and this, or I'm allergic to these ingredients, what do I do? And instead of you saying, well, not quite sure, or let me look it up, you can turn to hopefully a compounding pharmacist that would have some of that information for you and help you formulate some sort of customized or tailored medication for that patient. Compounding is a 5,000-year-old profession. Pharmacy in itself is old. It started off with apothecaries, but compounding in general, you think about back when they would take individualized ingredients and mix them together for a patient who came in and said, this is something is wrong with me. Can you make me something? And they would put the different powders or herbs or plants or ingredients together in some sort of solution or capsule and give it to the patient that way. So before manufacturing took over with commercially available drugs that were mass produced, compounding was in its original form in pharmacy. And so here it is again today. It represents about 3% of all pharmacy. There's a pharmacy on every corner that you've seen probably that your patients go to. And then there's your compounding pharmacies, who are a little bit more specialized than that. A lot of them may not carry those retail drugs. Some of them do, and it's kind of incorporated. But compounding is regulated by the state boards of pharmacy. So whatever state that pharmacy is licensed in, they are regulated by that state board. So if you work with a pharmacy who's in your state only and they don't ship out or do anything with other states, then they're regulated by your state board of pharmacy. If you work with a pharmacy who's nationwide, they're probably regulated in several states or all 50 states or something like that. Then they're regulated by each of those boards of pharmacy. So it can get to be, they're a very highly regulated area of pharmacy, depending on how many states they're registered with or licensed in. Compounding is also regulated by the DEA, both federally and on a state level, in terms of controlled substances and how those are being handled, made, shipped, etc. There are accreditation boards out there. PCAB is probably the biggest accreditation board for compounding. It is a division of ACHC, which some of you might be familiar with, that regulate some of the hospital pharmacies and hospital accrediting. So PCAB is a huge accreditation board for compounding that makes sure that the quality things are being done properly. The employees are doing everything by the book. Your equipment is up to speed. It's being inspected thoroughly. It's being kept compliant with current USP guidelines. And then NABP, which is the National Association of Boards of Pharmacy, also regulates compounding pharmacies as well. So you have to be compliant with all of those different regulating authorities. And then the FDA also has some authority to come in and inspect pharmacies as well. So they're always there for the protection of the patients as well. Compounding, to me, what we typically try to explain is that it's thinking outside of the box. And so that's kind of one of the things we want to think about today too, is that we get so ingrained, and me too as a pharmacist, ingrained in what is commercially available and what is FDA approved. And we're put into these down these particular pathways in terms of clinical guidelines and gold standards and protocols that have all of these commercially available drugs that you write a prescription for, send to the pharmacy, your patient goes and gets it. But sometimes that doesn't always work out for patients. There are those one-off patients or those cases where they just need something different, or maybe that the protocols or the commercially available drugs don't work for them, or they're allergic to them, or they have a sensitivity to them. They can't take something in there. Maybe they can't swallow pills, but the only thing that will work for them is a pill that you need to prescribe. So there's just so many little caveats that whenever you get that patient who may need something that you don't have access to, you would think compounding. It's a little outside of the box, but it's an option that can drastically change the way that you're practicing, just by having some other options available to you to think about, and for your patients to have better access to the drug medications and treatments that they need. I think about manipulating the dosage form. We can use the same active ingredients that are commercially available. You can see some pictures here. The top one is one of our non-sterile compounders just weighing out some materials. And then the bottom one, you can see the shelves at the back there just lined with, those are all bulk active ingredients that you individually weigh out. I mean, it could be sildenafil, tadalafil, prostaglandins, all the drugs that we're familiar with, Pitocin. There's so many different options. We have access to all these bulk chemicals that you can actually put in different dosage forms. So say you need some sort of suppository that has sildenafil, or a sublingual lozenge that has Pitocin. It really is about changing up dosage forms and getting the drug into the patient's body in some form or fashion using correct dosing. So very interesting. And then we talked about kind of just individualized medicine. How do you choose a compounding pharmacy? You might say, okay, great, that looks good, Tara, everything there, I could consider using a compounder, but how would I choose? You always want to make sure they're licensed in your state. If you have a compounder in your state that you practice in, chances are that, yes, they are licensed in your state. They are licensed as a pharmacy by your state boards of pharmacy. However, if you want to use more of a national one, there are national pharmacies that specialize in urology, specialize in urogyne, pelvic health, sexual medicine, OBGYN type pharmacies that specifically carry those drugs on their formulary, have the equipment and tools needed to make your particular dosage forms. If you choose a pharmacy that's like that is licensed outside of your state, just make sure they're licensed in your state too. So if they're located out of your state, you can just ask, are you licensed to ship to XYZ? And they will know that. You always want to make sure that you have access to a pharmacist. I try to stress this so much. It's so important that you have a pharmacist in your back pocket. They know a lot about drug entities. They know about pharmacology, how that drug works in the body, and they can give you a lot of information that you can save a lot of time looking up yourself. I know sometimes you guys are the best in the front line at the patient, knowing what's going on, diagnosing them. You see the patient firsthand. You diagnose their condition or disease, but the pharmacist can help you figure out what drug we should use. Or you may know the drug, but you don't know which strength, or maybe you don't know if there's a better way to make it work faster in the body, or if there's a way to make it preservative free, for example? Those are all really great questions and knowledge that your pharmacist should have, and you should have access to them via email, quickly call, text. I mean, it just depends on your relationship with the pharmacist, but I really do encourage providers to have a pharmacist in their back pocket, I like to say. I know that I was asked by a nurse practitioner to do this talk. So she's one that I work with on a weekly basis. We're always going back and forth on patient information and disease state and dosing. And she was like, it's great to have a pharmacist that I can just send a quick email to, get a response, and would you please, help out in giving more information. And so I'm happy to do so, but there are pharmacists out there and that's what they're trained on. So ask us, use us. We like to help. So you want to make sure that your pharmacy adheres to USP guidelines. So all compounding pharmacies, depending on the type of drugs that they do have to follow USP. If they do non-sterile compounding, they're following USP 795. Sterile compounding, they're following USP 797. And if they're dealing with hazardous chemicals, which there are a lot of hazardous chemicals, even your typical hormones are considered hazardous, then they are following USP 800 as well. So you just want to make sure that your pharmacy is up to speed on all of that, which they should be. They've been inspected on these points, so they will know, but it's good that they have a working knowledge of that and they're always striving to be USP compliant or better, and that they're doing proper testing. Another thing you want to consider when choosing a compounding pharmacy, just make sure that they have a portfolio that meets your practice needs. So there's a lot of compounding pharmacies who specifically just compound for veterinary use, or maybe they are just doing pediatrics or hospice patients. And that all depends on the different drugs that they keep in stock at their pharmacy. So if you call and say, hey, I need a sildenafil, apomorphine, fluoxetine, troche, and they're like, oh, we don't make those types of things. Well, then that compounding pharmacy might not have a whole, they might just do vet or something. You never know what all compounding pharmacy does, but there are some that specifically have the drugs available, and you should be able to ask and see, can you make this or can you make this? And then, so having one for your particular practice needs is important because you don't want to have to hop around and look for several different ones that can make different things. Pricing and patient care access, your compounding pharmacy should be competitive in their pricing. They should not gouge the patient in any way. There are several compounding pharmacies, so there is a element of best pricing out there. And the patient should have access to the pharmacy, pharmacist, patient care, quick access to get counseled, to find out, the status of their medication, if they need to get a refill, that type of thing. Reputation is always good. You want to make sure that the pharmacy that you work with has, a great reputation in terms of being able to take care of your patients properly, that you have good access to getting the drugs you want, and that they are of good quality. And there's a couple more, most importantly being accreditation, that they are accredited and inspected, and they are up to par with current guidelines and all of the quality QA, QC, and quality points that they should be. So some of the benefits of compounding, I won't go too far into this, but the main benefit is that you can have different options to what's commercially available. So instead of, for instance, I use progesterone. I know you guys may not prescribe a whole lot of progesterone in your fields, but the commercially available is 100 and 200 milligram gel cap. Well, there are patients who may need a topical cream or a 50 milligram dose because they are, slow metabolizers or something like that. So that's where compounding can come in and say, yeah, I can make a different strength for you. I can make it in a different dosage form. I can put two ingredients together that might be separate when they're commercially available, or at the retail pharmacy, your patient would have to get 2 prescriptions, versus in compounding, they can just get 1. It's all mixed together, and it just makes the patient more compliant, which is the next point. Increasing patient compliance, I think, is huge, both just because of being a pharmacist, we're always trying to increase patient compliance, be it just taking their medication on time, getting their refills on time, because we know that that is the key to getting the patient better. And for your sake as a provider, making sure that your patient comes back to you upon their follow-up or at their next appointment and they're doing better because they've been compliant with their medication. I always feel like as a pharmacist and having a pharmacy, it's kind of like if the pharmacy doesn't do their part in working towards patient compliance, then it's pointless for the patient to be going back and forth to their provider because they're not taking their medications anyway. So I'm always harping on with my staff, just increasing patient compliance. Let's find out what are these, is this patient sensitive to something? Can they not take a particular preservative or a dye, gluten, sugar? What is it that we need to what is it that we need to take out of their drug combo, or use a base that they don't have any ingredients that they're sensitive to, or switch up bases for them so that they can take the medication. Another benefit is that by putting things into transdermal preparations, you can avoid some GI upset that is a common side effect of some drugs, and you can also bypass the liver. So, for instance, I use metformin. It's typically always given orally, right? So metformin is available commercially at the retail pharmacy as an oral tablet. So, but one of the main side effects that we're always counseling on is this can cause GI upset, this can cause GI upset. And for a lot of patients, it may subside, but there could be that subset, or there are that subset that it just never does go away. And for those patients, we actually make them a transdermal metformin preparation. It doesn't even go into the GI at all. It goes directly into the bloodstream. It bypasses that liver metabolism. So they're getting that same drug effect, and they're avoiding all of those negative side effects. So just one example. There's some other ones that we can talk about later as we get into more of the urological products, but compounding can be affordable in ways where your patient's only getting 1 drug instead of 3 or 4 different meds. We're putting things into, of course, making sure that they're compatible, but into the same preparation. You have the better ability as a provider to adjust risk management profile and dosing. So for drugs with a small therapeutic index, we can make, tiny adjustments that can provide decreased risk to that patient of any kind of over or underdosing. And then the dosage form, obviously, being able to put the drug in different dosage forms is always a win. Okay, so here are some of the drawbacks. Compounds aren't typically covered on patient insurance plans. So that's what I was talking about earlier, finding a pharmacy that has good competitive pricing. A lot of them offer discounts on 3-month supplies, free shipping. They work with patients on payment plans and that kind of thing, because insurance doesn't usually cover drugs that are not FDA approved. However, it's always an option. Since it is a drug entity, they can still claim it on their insurance. So for you as a provider, you may just have to set an expectation like this might not be covered on your insurance, but you can still submit it. You can use your health savings accounts. You can still use your flex spending accounts and that type of thing on compounds, because pharmacies are still licensed as a typical pharmacy with the state. And cash prices, depending on the drug, I mean, it will matter whether the drug is a sterile or non-sterile compound, injection or oral or topical, but prices should be pretty competitive, and your patient really shouldn't be paying over $100 for anything, just as an FYI. They are not FDA approved, like I talked about. One of the drawbacks that I've found being a pharmacist in compounding for about 8 years now is that there's a general lack of understanding among the healthcare community about the role of compounding. So I don't think a lot of healthcare providers know that what compounding can offer them. And the ones that do are so thankful and excited to have an option. Even in the like dermatology realm, those providers are just like, thank you, I can finally put these 4 ingredients together that I've always wanted to. And once you sort of get that education going within the healthcare community and providers like you guys who are out here on the front lines with these patients and thinking, what do I do for them? Or maybe their insurance doesn't cover something that's very expensive and you're like, well, I'm sorry, that's all that we have. Or maybe we'll go down to something else, but it won't be as great of a product as that the expensive one would have been. Well, there's an option for looking at compounding. So and there is a lack of studies on compounded medications just because they haven't gone through the FDA approval clinical trial process. There are individual studies out there about the particular drug entities, and so we can kind of extrapolate from some of those depending on what the dosage form is, obviously, and the strength. So, but there in general a lack of, just because of the funding that it would take to do a clinical trial on something that is not going to ever go to market and in a manufacturer's eyes. So just keep that in mind. But I will show you some studies later that have some pretty good data on what we're going to cover. I'm not going to go over this slide because we kind of talked about it, but some great candidates for compounded formulations are patients who perhaps have allergies or sensitivities like we talked about, or the patient that comes back with you and says, I just can't take that. It really hurts my stomach, or it made me, feel this way or that way, or gave me rapid heartbeat or something like that, where you just need to have another option. Sometimes first line treatment options fail in patients, especially in urology, when there could be lack of blood flow to the penis, but yet they're trying to take oral sildenafil or tadalafil. So the drug is actually never getting to the site of action. Compounding can be an option for them. If they have particular strength or dose requirements that fall outside of the realm of what is available in your system or at the retail pharmacy, that's a good candidate. If they have any kind of contraindications, which we'll talk about later, disease states which prohibit them from taking a particular therapy that you have in mind for them, compounding can be an option. Compounding also is an option for patients or for drugs that are on shortage, back order, or discontinued by the manufacturer. So legally, a compounder, if there's ever a drug on shortage or back order, can compound that same drug. The patient can also preferentially desire a unique dosage form, something that makes them more compliant. For instance, maybe they require, or they would rather have a capsule of a drug versus a troche or lozenge, or vice versa. So those particular patients can certainly benefit. If they're having drug compliance issues, so this is a big one sometimes when it comes to patients who have to take a drug 2 or 3 times a day, we can formulate, or I'm sorry, compounders can formulate drugs into daily dosing or topical dosing that makes the patient a little more compliant in terms of not having to use it so frequently. And then flavoring and patability. This is used a lot in our vet populations and pediatric populations, but also across the board in terms of patients who can't take a particular medication because of the way that it tastes. So we can flavor it, make it more palatable. We can add color, flavor, like I said, sweeteners and those types of things for particular drugs that are maybe really harsh when given orally, whether in liquid or solid form. Okay, so let's get into some of what you guys are most interested in, why you're here today, is some of the conditions that compounded formulations can help with, or I'll give you some of these examples as we go along. These are the particular ones we're going to talk about today in depth: are erectile dysfunction, Peyronie's or penile fibrosis, premature ejaculation, testicular atrophy, vulvodynia or vestibulodynia, could also be clitoridynia, and then vaginismus, hypertonic pelvic floor, I think are the main ones that we'll have time for, since those are some of the big ones that we see from our urology practices. There are also many, many more that you guys might see. I know that you guys probably see a lot of interstitial cystitis patients, which there are compounded options for them in terms of intravesicular or bladder installations that we probably won't have time to get into today, but possibly towards the end. And then lichens conditions. We do a lot of different drugs really that can cover a whole realm of particular urological conditions. So we will get right into erectile dysfunction to start off with. I love this graphic because it really helps me see and explain visually how erectile dysfunction happens, and then why we're even using these particular drugs that we do in compounding. So this is obviously a smooth muscle cell here. So this is what is located in the penis, in the corpus cavernosa, the penis specifically, that we're trying to relax so that we can get blood flow into that area to cause an erection or to cause tumescence. So there are several different ways to relax a smooth muscle cell, one of them being increasing nitric oxide. The main one that we're going to look at is keeping cyclic GMP in the cell. That helps through a down cascade or a downstream cascade of events, cause smooth muscle relaxation. And then just working with the sodium or the calcium potassium pumps in terms of keeping that smooth muscle cell relaxed and allowing blood flow into the area. So and then I have this flow chart here. This came directly from some of the guidelines in the Lancet, but when we talk about erectile dysfunction, there's always, as you guys know better than anyone, there's always several components that could go into what is causing the erectile dysfunction. So you always want to look at, obviously, psychosexual and couples therapy, especially working with a lot of the sexual health clinics and providers that are getting a lot into sexual medicine these days is becoming a hot topic in terms of therapy, counseling, education, because there's always that psychosocial component to it. But for some men, there's not. It's just a possibly hypogonadism, different lifestyle modifications that are causing the erectile dysfunction potentially. I've seen patients who are on opioid therapy that are unable to have an erection, which I'm sure you guys have too, young men too, that are seeing the side effects of some of this drug therapy that they're on, not knowing that it's what's causing it. But a lot of the times, it's a testosterone. In your older population, obviously, for primary hypogonadism, it would be due to a loss of testosterone. And then also in some of your post-prostatectomy patients who have some nerve damage there as well. So your first line would be the PDE5 inhibitors, which you guys are familiar with as sildenafil, tadalafil, all the fill drugs. Those are always going to be your first line in patients who don't have contraindications to the medications. If those do fail, or if they have some sort of contraindication to taking a PDE5 inhibitor, you're going to look at some other options, one being intracavernosal injections, which we'll get into a little bit today, just in terms of penile injections being, so many are compounded. So there are 2 commercially available options, but the majority, when you're getting into combinations, are compounded. So I'll go into that a little bit more, and then some other options for PDE5 inhibitors. So on this slide, I know it's busy, and in school when they say, you better listen to what I'm saying because I'm going to say something that is going to be on the test and you better write it down. Well, that's not the case here. I just put everything on my slides so that you don't have to take notes. That's my excuse to why my slide is so busy. But you don't have to take notes because everything I'm going to say pretty much is here, and I want you to have it so that you can look back on it and use it. But when we're looking in terms of compounding, we know for erectile dysfunction that we have the drugs that are commercially available out there that are oral for the most part when it comes to the PDE5 inhibitors. However, in compounding, we make a lot of erectile dysfunction therapies that are buccal, which is between the cheek and the teeth, so that pouch there, the buccal pouch, and then sublingual therapy, so under the tongue. And a lot of the reasons that we make those particular drugs in those particular dosage forms is because of the advantage that the onset is a lot quicker. For a lot of men waiting for that oral, Viagra or Cialis to go into effect is a waiting game for many, especially if they've eaten a high fat meal. That can decrease the absorption of the drug in the system. So man goes out for big steak dinner and goes home, takes a little blue pill, and it's taking forever for it to go to work, or maybe it isn't going to work as effectively as it should have, both because he's waited so long and then also because he had that high fat meal. Those are some of the counseling points that as pharmacists we talk a lot about when it comes to counseling patients. However, for those men who are needing or wanting, or maybe the provider says, there's another option if that's what's causing you to still have issues or to still have decreased erection or tumescence, then here's another option, is a buccal or sublingual route. It does bypass first pass metabolism, so it goes directly into the bloodstream. There are a lot of capillary blood vessels in the buccal sublingual space. You don't have to worry about food, so it goes directly into the bloodstream. You don't have to worry about oral absorption or bioavailability. And then also the third advantage is that you can sometimes do dosing adjustments on the lower side. So you actually sometimes are able to give the patient a smaller dose and achieve the same effect because there is higher bioavailability in the buccal and sublingual space than giving it orally. So for instance, if you're giving a man sildenafil 100 orally, you may be able to give him sublingual sildenafil 50 milligram and it have some of the same effect on him, just because it's being used it's more readily available. So the two main ones, obviously, that we've been talking about are PDE5 inhibitors. Their mechanism is that it keeps cyclic GMP in the cavernosa, causing smooth muscle relaxation. So if you think back to that little graphic, it does help relax the smooth muscle, allowing blood flow into the penis. The goal for therapy, obviously for any patient, for any dosage form, is to find the dose that meets their expectations without resulting in unacceptable levels of adverse effects. So we're always worried about orthostatic hypotension with PDE5 inhibitors. We're always thinking about priapism. So just keeping those in mind, finding the dose that works best for them, start low, go slow, is a lot of the mantra that us as pharmacists, and I know you as providers sometimes use. Dosing for sildenafil, and we're talking about buccal and sublingual dosing for compounding, is typically 20 to 50 milligrams on sildenafil, and then tadalafil we're looking at 5 to 40 milligrams on tadalafil. An interesting compounded option that you can do is adding fluoxetine into the formulation. It has been shown, and there's a study I'll show you guys, to decrease the event of premature ejaculation. So if you have a patient who's also experiencing some PE along with erectile dysfunction, adding a little fluoxetine in there has shown, even in as low as 5 milligrams into their sublingual troche or sublingual lozenge or buccal lozenge, that can help with that. I'll show you a study in a little bit, but there's one in the Journal of Urology in 2004 that went over sublingual sildenafil. So it was just showing that 65 patients who received the sublingual sildenafil achieved satisfying erection in coitus versus a 15% in the placebo group. Now, we all know that N equals number is always important in your study size. And there was only 20 people in this study, but I thought it was interesting that they did the sublingual. They wanted to see what the sublingual did, and that's a pretty significant difference there. The mean onset of action with sublingual therapy was 15.5 minutes and lasted an average of 40 minutes for the erection time. So, excuse me. So you can see there it did go to work pretty quickly, whereas we know some of the oral meds can take a little longer than that. Another drug that we typically do a lot sublingually is oxytocin. Oxytocin is considered a hormone. It's more of a neurotransmitter, but it is sometimes referred to as the love hormone. So not so much erectile dysfunction, but more studied in the areas of arousal and desire, and just kind of like that love and that cuddle hormone, the feeling of, being held. Oxytocin is released a lot when you hug people for an extended period of time. So that is sometimes, a good additive to some of these therapies, or oxytocin used alone is also good, male and female, in a dose of 40 to 100 IUs. It's dosed in units daily, and then you can do one before sexual activity as well. So very interesting drug. A lot of really cool studies out there on oxytocin right now. They've used it for addiction medicine. They're using it for some like depression and anxiety type issues as well. So, but in terms of if you're having a patient who may just need that extra boost of arousal or desire, along with their erectile dysfunction, or maybe they don't have erectile dysfunction, they just want to get more mood, oxytocin is a great option. Apomorphine is very, very interesting. We typically combine apomorphine with a sildenafil or a tadalafil into the same sublingual like preparation. So whether it's a sublingual drop or a sublingual lozenge or like gummy bear or something like that, it also helps enhance that sexual response signaling. It actually stimulates dopamine receptors, causing the smooth muscle relaxation in the penis area. So that kind of is pretty synergistic with the PDE5 inhibitors and has shown some pretty good results. Here's a study I was talking about just for your reference, the sublingual sildenafil in the treatment of ED. You're getting a faster onset of action with less of a dose. And then here's a small study on apomorphine that I was talking about during using it for erectile dysfunction. And the opinion is that it's not first-line treatment, but it is available, and it is more effective than placebos in treating the ED. It's generally well tolerated, and there's hardly any side effects there, and with the ones that are tolerable. Nasal sprays are also available. You can really put, that's a cool thing about compounding, is that you really can put the drug into any type of dosage form that you desire, and what works best for the patient, so that they are compliant with their treatment and they ultimately get the result that you guys are looking for and that they're looking for. Okay, so let's talk about trimix. This is really cool. Y'all have probably heard trimix before, or bimix, or quad mix. I've heard super duper mix. It's all over the place, but the main point is that this particular route of administration, an intracavernosal injection, delivers drug directly to the site that it needs to be in. So for your patients who may have contraindications to oral or sublingual PDE5 inhibitors, maybe they have some sort of cardiovascular risk factor that they are unable to take those. Men who are post-prostatectomy, spinal cord injuries, these types of patients, even diabetes, ones who aren't getting proper blood flow to the area, or who have nerve damage to the area, are perfect candidates for intracavernosal injections, because it's independent of nerves and blood flow. So you're getting the drug directly there. It's causing direct smooth muscle relaxation in the cavernosum, and causing an immediate less than 5 minutes erection. So for those men who are on the go, spontaneous, or need something quick and effective, these particular medications are really great for them. And I always say intracavernosal because that's the most popular, I guess, way of getting the drug into the site. But there's also some really great studies, and I've seen some really cool urethral suppositories made that carry these drugs. They aren't as effective just because of the absorption isn't always 100% like it is with intracavernosal, but I have seen them work in patients who may be unwilling to give themselves an intracavernosal injection. This is also good, like we showed in the guidelines a little bit earlier, for patients who have failed the first-line therapies. This is another option for them. And then stepwise dosing, which I'll show you a chart about, is really interesting in terms of being able to have a particular strength of trimix for your patient, but they can kind of, you guys, and they can kind of titrate to the dose that they need. So if a 0.2 ml dose isn't working the best for them, or they're only achieving 30% tumescence, you can kind of go up a little bit on the next dose to maybe 0.4, 0.5 mLs, and they'll actually hopefully achieve a better erection. So it is a titratable dose and a dose dependent relationship there. So here are some of the drugs that are included in some of these particular medications. Now, this is a sterile compound, so this does have to be made in a sterile compounding pharmacy that's compliant with 797 that we talked a little bit about earlier. Not all pharmacies do sterile compounding. Some do only non-sterile, some do only sterile, and some do both. So just make sure that the pharmacy you're working with does sterile medications, and they have those proper facilities that with the clean rooms and the 797 USP compliant labs that they can make these medications so that they are sterile and made in an aseptic technique. So some of the drugs that are included in these, and we'll go over a little bit later, but papaverin is one of the drugs that is popular in the trimix formulation, and it prevents the inactivation of cyclic AMP, and it prevents the degradation of cyclic GMP. So in that case, those two stay in the smooth muscle cell, accumulate, and then promote relaxation of the smooth muscle. The dosing on papaverin is 15 to 50 milligrams per ml, or 15 to 50 milligrams per suppository. It usually starts off on the lower side, and then your patients can move up as they need to or require. Phentolamine also causes smooth muscle relaxation by blocking the postsynaptic adrenergic receptor, and that speeds up the onset of tumescence and rigidity. So it kind of works synergistically with papaverin. All these drugs work synergistically with each other. So they all kind of have different mechanisms of action, which kind of hit the condition from 3 or 4 different mechanisms in order to cause the erection. So very interesting. And on that one, phentolamine is dosed from anywhere from 0.5 to about 4 milligrams per ml, or 0.5 to 4 milligrams per suppository. Prostaglandin, you guys are probably most familiar with. There are 2 commercially available drugs on the market that have prostaglandin only, but this drug is very effective in relaxing the arterial smooth muscle. It produces vasodilation and allows the blood flow to come into the penis and be entrapped in the lacunar spaces, which in turn helps bring more blood flow to the area and provide an erection. And then important note about prostaglandin is that it's dosed in micrograms, not milligrams. So micrograms, anywhere from 5 to 100 micrograms per dose or per ml or suppository. The fourth one isn't always included in the trimixes. If this is included, it's usually called a quad mix, so it has the 4 ingredients total. But usually patients are able to not have to use atropine, and they achieve the desired effect with just the top 3 ingredients. Excuse me. But atropine binds the muscarinic receptors, and muscarinic receptors are actually involved in the contraction and relaxation of smooth muscles. So just another way that you can achieve that effect. This study here is one that we initially looked at in 2002, talking about intracavernous injections. And this was particular in patients with cardiovascular diseases, or if they had some contraindications to sildenafil citrate, which is the PDE5 inhibitor. So in those particular patients, they went to cavernosal injections and showed really great results on there. So they are good alternatives or second-line treatments. And then down here in red, I just put some of the terms that you might hear out there in the industry in terms of somebody saying, or your patient saying, I want Trimix, or I've been on Bimix. You will kind of know that it may differ from pharmacy to pharmacy exactly what strength and ingredients are involved, but for the most part, Bimix does not have prostaglandin in it. A Trimix has the 3-letter P's, so prostaglandin, papaverine, and pentolamine. And then Quadmix is just like Trimix, except you add atropine. And that's sort of industry standard. You may want to check with your pharmacy, make sure that what their formulations are. And then Trimix injections, just for FYI for your patients, they do typically wear off naturally. We say, they shouldn't last more than an hour. It just kind of is the same time frame as your oral medications would. Their body naturally excretes that or circulates back into the body. We are always counseling on priapism, an erection lasting greater than 4 hours. Obviously, we'll need to seek attention for that. There are antidotes for priapism, namely norepinephrine, pseudoephedrine, phenylephrine are the ones that we commonly recommend. There are pharmacies who make the phenylephrine antidotes. Other words, patients, typically can get the erection to subside with cold showers, ice packs, sometimes black coffee, anything to get their blood pumping and try to circulate that blood flow from the penis. Another thing that's really interesting about these injections is that a lot of clinics or practices that I've worked with in the past personally have used the Trimix injections for Doppler testing. So they'll typically, and you guys several of you probably have done this before too, but that's what they use for the Doppler testing to see the blood flow in the patient and seeing, what kind of blood flow either in or out that they're having from the shaft, and using that Trimix to kind of cause that immediate erection and then seeing what happens from there. So we get a lot of orders, particularly for Doppler testing. So this is actually a chart that we use in our pharmacy a lot. It's actually from your organization, SUNA, and it is talking more about the stepwise approach of using the intracavernosal injections, and how patients who depending on whether or not they've had a radical prostatectomy, a history of ED, what their age is, kind of the dose that you can start them out on, and then depending on whether or not they have pain or whether or not they're getting the particular strength that they want, how to titrate that dose. So they can typically recommend starting off at a lower side injection, and then depending on the patient's reaction, going up a little bit. If they have pain, sometimes the prostaglandin can cause a little pain, so a lot of providers take that out and just go with the Bimix if the patient has pain, and that tends to solve the problem. But the dose titrating is really great because you can actually teach your patients how to do this in the office, find their perfect dose while they're there, and then send them home with a particular prescription, knowing exactly how much they're going to use. A lot of other clinics who are more comfortable with their patients knowing how to titrate it on their own can let their patient know, like, here's what you would start out with, probably 0.2 milliliters of this particular formulation. If that doesn't work, then next time do 0.4 milliliters, or however stepwise up you would prefer for your clinic. But a really good counseling point that I love to tell patients is that they keep a journal. They can write down what strength they're using, how much they injected that time, and on a scale of 1 to 10, or using a percentage from 0 to 100, what percent tumescence did they have, or what do they desire? I always also make them write down, just from a pharmacist standpoint, I also make them write down their lot number of the drug that they're using, or their vial of Trimix, and then also the expiration date or the beyond use date on the vial. Because, we all get those calls that are, hey, this medication isn't working. And I'm like, okay, let me know, send me a picture, or tell me what your beyond use date and what strength you're using. And it's like from 6 months ago. And I'm like, well, you probably need a refill. So that's always good for them to keep a log of that, so that you can see exactly what they were trying, and then finding the perfect dose. Okay, so let's move on. The rest of them obviously aren't going to be as long as erectile dysfunction, because that's always the biggest one that we hear of. So the next one, we'll look a little bit into Peyronie's, or otherwise known as penile fibrosis. This condition consists of, it's a connective tissue disorder actually that affects the penile shaft, leading to a deformity. So a fibrous plaque forms in the tunica albuginea and causes that curvature. There are several different ways that it can be treated, both minimally invasive, but also surgical options, drug options. The ones that we use from a compounding standpoint, if the patient has tried other things but doesn't necessarily want to go to injection or surgical treatment at the time, is verapamil. It's a calcium channel blocker, and there are some pretty good studies showing that it inhibits the fibroblast proliferation in the plaques, which helped improve the curvature of the penis in this particular study in 91.7 of the patients, and decreased the plaque volume in those patients as well. For those who do have pain with plaque, the verapamil did help with the 100% pain resolution in those patients, and did improve erectile dysfunction in 71%. So those are some pretty good numbers of a small population, but we've used this one in our patients, and we've seen good results from it. For that, we do a 15% verapamil cream applied twice daily to the shaft. And then here's another study showing using iontophoresis, which I'm sure a lot of you are familiar with, but they actually used a verapamil and dexamethasone combo, which can be compounded as well, those two ingredients, instead of having to get them separately. And then showing great improvements also in the pain, curvature, and plaque size in those particular patients. So just really interesting ways to use drugs that we don't think about. We think about verapamil as, a heart medication, or a blood pressure, but actually, it has other mechanisms that can actually break down fibrous plaque. Vitamin E is used a lot by patients who don't want to go directly to drug therapy. Perhaps they just want to have something sort of natural, I guess, that they can try first. And we do a dose of 500 units per gram of vitamin E. It's a cream. It's actually like an ointment to help occlude it onto the site of the plaque. And then there's a neat little study there showing that it revealed some improvements in plaque size and penile curvature in that particular group. So just two drugs here you can think about in the back of your mind in terms of thinking outside of the box when you get these particular patients. We know that there's other drugs out there. Orally, there's pentoxifylline and colchicine. You can do actually injections into the side of the plaque with verapamil, so verapamil injections. You can do the iontophoresis is always a good idea. So just having all your options, I feel like, is also really important in terms of being well-rounded in your diagnosis, so that you have You can lay everything on the table and then decide what you're going to use. So I always like to provide the options for you guys out there who are seeing these patients and just want to know all the information like I do. Okay, PE. There are guidelines out there on PE. I used, well, just to get the definition and everything, I used the International Society for Sexual Medicine, but PE is characterized as ejaculation that always or nearly always occurs prior to or within 1 minute of vaginal penetration. That is the textbook definition. I speak with providers who say premature ejaculation for my patient is faster than he wanted to do it. And so I say, okay, well, that's perfectly fine. For a male patient who feels like they're not, they're ejaculating beyond or before what they expect or what they want, then for some that could be a diagnosis, but typically it's within 1 minute is the technical definition. In patients who have concomitant erectile dysfunction, you should always treat the erectile dysfunction first. You guys know that, but that's typically one of the counseling points that I tell the patient too. Like if you also have PE or if you also have ED, we need to get that corrected, and then we can talk about the PE. And there's some drugs that we can actually use one drug and it'll help with both. So let's see. Also, when patients are treated for ED, sometimes the PE, premature ejaculation, can improve on its own. In patients that don't, there are some options out there. Like I talked about earlier, fluoxetine and the SSRIs were studied in even being able to combine them with, like, say, a fluoxetine or sildenafil. Oh, I'm sorry, go back. So in a fluoxetine or sildenafil dosage form where they can be put together, helping with the ED issue, but then also with the PE. 5 to 20 milligrams a day is typically the most effective. After a week, some patients do have to go up to about 40 milligrams. That's been successful as well. It really just depends on the patient and what their expectation is. We're all familiar with EMLA. That's commercially available. There are ways to compound other combinations of the topical anesthetics. So for instance, I put lidocaine, prilocaine, 3%, 3%. It's just a stronger dose than EMLA, but you can do benzocaine, lidocaine. You can do lidocaine, tetracaine, prilocaine, depending on how long you want the anesthetic effect to work. So patients do want to do this important counseling point 20 to 30 minutes prior to intercourse. Give time for the drug to work on the shaft of the penis, and then for the patient to rub off the excess, because you do not want to transfer that to the partner. That will just cause them to obviously get anesthetized in that area, and it might not be good for anybody. But that has worked for premature ejaculation, just allowing men to last a little bit longer. And then it has been shown that a prolonged application, so if it stays on too long, the patient can actually lose the erection due to numbness. So you don't want to do too high of a dose and for too long, or too much of it being used, where it's actually having the reverse effect and patients are getting frustrated. But it is pretty effective for PE in terms of in the short term. Bimix has also been studied. We talked a little bit earlier about the intracavernosal injections, particularly Bimix, because of the papaverine and pentolamine, has also been studied in patients with premature ejaculation. Yes, it will cause it will cause an erection, but it also kind of helps with PE, just keeping that ejaculatory response from happening too suddenly. So the next slide, I just kind of show some of the guidelines that I got from ISSM. I like to look at these and just make sure that I'm staying up to date on what's out there for PE, so that I can properly tell you guys about that. The next slide we have is testicular atrophy. You guys know that penile growth is under androgenic control. So anytime that you have testicular atrophy or micropenis, it could be they are typically both presenting symptoms of IHH, which is basically a type of hypogonadism. And then that's one way, is that you don't have the particular testosterone to accommodate the testes, but then also patients who may be on exogenous testosterone replacement therapy could also get testicular atrophy as a result of that, because it's the exogenous replacement of testosterone is telling the body, you don't have to make testosterone anymore. You can, stop, which causes the testicular atrophy. You guys know this. But one way to treat that, and that can be compounded, is HCG. It's human chorionic gonadotropin. It has a stimulatory effect on steroidogenesis from the testes. It causes the Leydig cells to produce testosterone, which in turn kind of gives that growth back. Typically, dosing is pulsatile, so 3 times weekly, anywhere from 1,500 to 2,000 IUs. So it's the higher dose. You can get this compounded in a high dose injectable that's 5,000 units per milliliter, is a pretty high dose. That way they don't have to be using so much fluid when they're injecting it. It is a sublingual injection, and it can also be made into a nasal spray or a troche when it's compounded. And then here's a study here showing that 20 men with micropenis presented starting an 8-week treatment with HCG, and there were no adverse effects shown in the HCG treatment set. And the HCG treatment increased the serum testosterone levels by, like we said, it produces testosterone secretion from the Leydig cells, so the man is able to produce testosterone on his own. It increased penile length and testicular volume in those particular patients. So just an option if you see those patients, even if they don't want to do an injection of sorts, there are ways to do nasal spray, troche, sublingual drops I've seen. So there are ways. And here's the study that goes along with HCG for IHH, or testicular atrophy and micropenis. All right, let's talk a little bit about the girls, the women. So we do get lots of inquiries. I do as a pharmacist, particularly from urogyn's, advanced practice providers, and those working in the urology gynecological space in terms of female issues and female conditions, especially sexual health type problems, or patients who are coming with post-trauma or from the even the transgender communities. We're getting a lot of requests about how to make particular therapies for them. So I don't want to leave out women. If you don't see women in your practice, then this may just be an FYI, but it is good to know that there are options out there in terms of compounded medications. There's not a lot available commercially, so sometimes you must turn to compounding in terms of getting the particular drugs that you need in the correct dosage forms that are made specifically for this area. Some advantages to using compounds is that you get local therapy. So a lot of the times we think of, if a patient has some sort of nerve pain, just give them oral gabapentin. Well, oral gabapentin goes into the bloodstream, goes all over the body, not something that a lot of people might be able to tolerate or want to, have all that systemic absorption there with the gabapentin. So you can actually get a gabapentin cream compounded that's applied directly to the site. It works right there at the nerve ending in the vestibule or the vulva, and has the same effect. So just different ways of looking at a particular drug therapy in a different dosage form that's achieving the same result. So other advantages are that you can get pH balanced, preservative-free, alcohol-free preparations that are compounded. These patients are typically overly sensitive in the first place. So using a commercial grade ingredient out there that's meant to be put on the skin or for some sort of dermatological issue. Having the patient apply it in the vaginal area and the mucosa there can sometimes not, it can be painful or not appropriate for that area in terms of the excipients that might be in that cream. So I like to put on here that the therapy is directed at the diagnosis. So if you're diagnosing vulvodynia, vestibulodynia, clitoridynia, something like that, you're prescribing a medication that is used directly for that condition at that area. So you're treating the you're treating vestibulodynia with a vestibular cream. So it's just giving you a more directed approach and access to something that's available for that patient. So vulvodynia and vestibulodynia, it can be hormonal or it can be neurologic in nature. So it can be due to the nerves, it can be due to hormone changes. But regardless, once you figure that out, there are different formulations that can be put together for those particular patients in different dosage forms. So creams, ointments, suppositories, even vaginal foams we make that have great coverage. And then you can use different drugs that are synergistic with each other that use several different mechanisms of action depending on if it's muscular, if there's a muscular component, hormonal component, nerve component, finding those particular drugs, and we'll go over some of those. So vestibulodynia or vulvodynia that's neurologic in nature has a particular subset of agents that we can use for them. So the rationale for using these agents is that women with vestibulodynia have a congenital disorder with significant increase in the number of intraepithelial nerve endings within the vulvar vestibule. And there's a study that shows that patients with condition that is neurologic in nature do have an increased number of nerve endings there. It's so interesting. I love this this picture because it really shows how innervated that area is, and that, you know, if those nerves are exposed or if they're having some sort of, you know, atrophy or had some sort of surgeries or radiation or chemotherapy type agents that have caused those nerve endings to be affected, then there are drugs that can be particularly used there. Another study showing a higher number of nerve fibers reported in the vestibule of women with vestibulodynia compared with the women in the control group. So some of the agents that we can use, and these are all topical, so these are all made into creams or suppositories. They're not given orally for these particular conditions because we want to get the drug right at the site, like we talked about. Are gabapentin, ketamine, amitriptyline, baclofen, cyclobenzaprine, and lidocaine. So those are several different, six different drug products that we can put in different combinations, particularly for this condition. So very interesting to get to choose which drugs you feel like will work best for your patient, depending on if you feel like there's a muscular component or not. But looking into some of these mechanisms of action, for instance, gabapentin, it targets areas of the nerves that control the concept of pain. So it works directly at the nerve endings. We have a study here showing that 80% of women demonstrate at least 50% improvement in pain scores. And then sexual function improved in 17 of 20 patients with evaluable results. Ketamine actually inhibits the NMDA receptor and blocks the calcium channel and depresses the sodium channel to help with the actual transmission in the cholinergic transmission of pain to the brain. So we use a lot of ketamine in female patients with neurologic vestibular and vulvodynia. Also, men with proctodynia, we use a lot of ketamine in for that particular pain. One of the most popular compounds that I've seen is called ABG cream. So it's amitriptyline, baclofen, and gabapentin, and it's used in combination with each other. You use all three of them together, and they actually work in 3 different ways to help with pain in the vaginal area. So it's very interesting if you are able to diagnose a patient with a neurologic case of one of these conditions, then that's a great place to start instead of going directly to pain medications or lidocaine or something that, is just kind of putting a band-aid over the pain. You're actually looking at helping at the nerve ending itself, at the muscle itself. If there's any spasms or, tense hypertonicity in the particular muscles there, using cyclobenzaprine can help as well. So you guys can read a little bit more about some of the indications here. And then vestibulodynia and vulvodynia can also have a hormonal component to it. This is a lot of the cases that we see, but you will know depending on, where the patient is in life, how old they are, or what, if they've had, prior surgeries or hysterectomies, oophorectomies, which cause them to not have hormones, or maybe some sort of post-cancer diagnosis or something like that that's causing the pain in that area. But estradiol and testosterone obviously are going to be the two biggest hormone components that are compounded. Vitamin E also helps with that collagen elasticity in the area, so that's a great one to add into your compounded medication. Lidocaine can also be taken in or out depending on if the patient prefers that, with, if they have pain upon penetration or something and they need that lidocaine there, either with the combination of drugs, or if they just want the lidocaine separately on the side, that's always available too. And then there's also a DHEA option, perhaps for your hormone naive patients or those who are cancer survivors who would rather have something that is more upstream than the particular hormones. So you do see in the hormonal vestibular vulvodynia or even vaginal atrophy, you can, patients who were previously on some sort of oral contraceptive in the past, or started oral contraceptive at a young age, can actually have an increased sex hormone binding globulin concentration in their body, which decreases the free testosterone and estradiol that are circulating. Therefore, that sometimes those patients need the hormone replacement vaginally. This is one of my favorites because I like stuff like this, but vaginismus or hypertonic pelvic floor disorders, also called levator ani syndrome, levator ani hypertonicity, call it what you want to, but basically you guys probably see this a ton where the pelvic floor or the levator ani system of muscles is so hypertonic that it's causing pain, either causing bladder issues, bowel issues. That muscle runs from the pubic bone to the coccyx. So you can imagine, male or female, every structure that that muscle is part of can cause pain. We typically see it in patients who are post-surgical or who are new to like vaginal intercourse and having that sort of fear. But we use a lot for this particular condition. We use a lot of diazepam vaginal suppositories, starting at a 5 milligram to 20 milligram dose. And then you can add in baclofen, lidocaine, ketamine, amitriptyline, depending on your patient's response to the diazepam, or if you know that there may be a little bit more nerve damage there, or possibly they want to use this before intercourse or something like that. But diazepam is a very interesting drug because we all think of diazepam as oral Valium, right? So for anxiety, it's a very calming drug. It helps with anxiety. It helps with sleep. Sometimes people use it, but diazepam is very interesting because when it's given topically or in a suppository and it's able to diffuse into that muscle, it actually acts as an antispasmodic. So it binds to the GABA receptor. It kind of helps that down regulation and opening the membrane channels and just kind of letting that muscle relax out a little bit so that it's not squeezing on or causing the hypertonicity or the high resting tension in all those structures in the pelvis. So there's some pretty good data on vaginal diazepam and then also rectal diazepam for men who are have this condition, but goes into effect pretty quickly. About 1.5 hours is its peak concentration. About 90% bioavailable. This is the rectal data on diazepam, and then is out of the system in about 46 hours. So you can, we do recommend patients using this for the first couple of weeks daily, but then they can go to 2 to 3 times weekly thereafter, depending on their symptoms, and you don't have to use it as often once those receptors or those GABA receptors get saturated. You can kind of go down to some less frequent dosing. Okay, so that is all we have in terms of all the different conditions and the drugs used. I wanted to go over a patient case here just to satisfy some of our CE requirements and also help meet a little bit more of those objectives. But you guys see these people all the time, so you are the expert. And your pharmacist is your support staff in terms of helping you dose. But you guys see the patient. You probably are going to get this real easily. When I give this talk to pharmacists, we have to, talk like a little bit more in depth about it. But this man is a 66-year-old male. He presents with ED according to, he took the IIEF questionnaire in your office, and it did show that he did have erectile dysfunction, or it did qualify that. He complains of time to erection, so he says it takes too long if he's taking some of those other medications. He's happily married, so we don't think of any psychosocial issues, and he's retired, so he has some time. And I actually did have a patient who I was speaking to on the phone, and he just told me that my get up and go got up and went, and I will never forget that. That is the funniest thing I had heard in a while, and I was like, okay, well, let's get you back up and going again. So just something funny there for you. But past medical history, he did have a prior cabbage in 2018, and but that is controlled. And then he does smoke half a pack per day, denies any illicit drug or alcohol use. He is a diabetes type 2 patient, but that is also controlled via his PCP. So his current medications, he is on testosterone topical gel that he gets compounded daily. He's on a simvastatin, atenolol, 81 milligrams of aspirin, and metformin for his diabetes. His blood pressure sitting in your office in the right arm was 130/65. You did try a penile echo Doppler measuring the blood flow, and that showed normal, and there was no nerve deterioration on biothesiology. So we kind of ruled those things out. So what is your diagnosis for him? Probable cause, first of all, is there is probably a neurogenic component there with the diabetes, maybe some sort of neuropathy. We don't know for sure, but it is definitely a contender. Hormonal, he is on testosterone, so it likely is controlled by his PCP. It'd be good to run that lab and see. But testosterone is crucial in libido. So sometimes that can be a contributing factor if he's not properly controlled on, or he's not at a proper level for his testosterone. And then atenolol. Atenolol is actually a beta blocker, which can exacerbate ED. So it's an FYI for you guys, but there are certain drugs that can attribute to sexual dysfunctions. And then his major risk factors are smoking, diabetes, and hypertension. And of note, we want to remember he did complain to time of erection. So we're thinking, okay, let's get him something with a faster onset. He did have a cardiac past medical history and hypertension. So let's think of oral PDE5 inhibitors with heart conditions. And let's check his testosterone levels, make sure those are looking good. And is there any atenolol alternatives? Maybe we can look into that for him as well. But for today, let's start with this treatment. We are going to look at a trimix, so a papaverine, phentolamine, prostaglandin combo, 30 by 1 by 10 strength. Have him start with the 0.2 mLs prior to sexual activity, and with the ability to titrate up by 0.1 ml until tumescence is achieved. And then, as always, on a smoking cessation plan. So that's what I would do for this patient. That's what I would recommend if he was amenable to it. If not, there are urethral suppositories we can do. I'm sure you guys have some other options. There's always penile pumps and those types of things. Maybe even correcting all of his other factors before trying trimix, or even maybe a sublingual PDE5, although that may, with the cardiac warning, we don't want to push that too much, but could start off on a lower dose and watch it. So here are my references. If you guys are interested, I also have them for each slide if you need those. I think they're in the PDF, but I just wanted to say thank you guys so much. I really enjoyed presenting this to you. I hope you learned something, if anything, today. And the main goal always is to have the best options for your patient, and knowing that there are other options out there.
Thank you for listening to the webinar on compounded formulations for urologic conditions. I hope that you got some great takeaway information and learned something new that you can put into your practice today. The Innovation Institute was designed to provide you with the tools and education that you need to help grow your practice and increase your knowledge base. If you enjoyed this lecture, I invite you to continue learning by signing up for the next webinar in our online series. To do so, please visit our website at www.innovationcompounding.com. As always, the pharmacy team at Innovation is here to answer your questions and listen to your feedback. So please reach out to us at any time. Again, thank you for listening, and be well.